slide.
Yes.
And
Yes.
then,
Okay. Go ahead.
I was sharing. So, Dr. Gao, you may start whenever you're ready.
Yes, I'm ready. Good morning, Dr. Carlos, Chen Chen, and all my friends in St. Jude, Memphis. Good evening, all my colleagues and friends in China. Welcome to St. Jude, Shanghai Children's Medical Center Pediatric Oncology Seminar Series. The topic today is Langerhans cell histiocytosis. Next. The microphones for the participants will be muted to avoid background noise and echo, but you can enter your questions in the chatting area. Our moderator will address all the questions during the discussion session. In this 1-hour seminar, a 40 minutes lecture and a 20 minutes discussion time is scheduled. Our guest speaker from St. Jude will sharing with us his knowledge about pathogenesis, diagnosis, and treatment of pediatric LCH. And all the participants and the audience can discuss and identify potential collaboration opportunities in the future. Before we start the seminar, I will introduce all the presenter and the participants today. I'm Gao Yijing from Shanghai Children's Medical Center, Department of Hematology and Oncology. Clinically, I'm a general pediatric oncologist, but personally, I have special interest in pediatric lymphoma and histiocytic disease. Dr. Carlos Galindo is the guest speaker of this seminar. He is also the co-host of this disease-specific pediatric oncology seminar series. As we know, Carlos serves as the director of St. Jude Global and the chair of the Department of Global Pediatric Medicine. He is also the executive vice president of St. Jude Children's Research Hospital. Dr. Carlos responded to our initiative for this seminar actively and gave us lots of help in speaker invitation and seminar organization. Carlos, welcome. Would you like to say something to our Chinese audience and participants?
Yes, thank you. Thank you so much, Dr. Gao. It's a pleasure to be here. I'm very happy to see that these seminar series are going very well. I heard that very good feedback from other seminars, and I hope that over the next several weeks and months we can continue to do them. As you know, from St. Jude and from our department in St. Jude Global, we are here to support SCMC, to support all the Chinese institutions in helping advance knowledge through these seminars, but also through these direct interactions that we have in trying to optimize research, try to answer the most relevant questions and advance the field of pediatric oncology in China. So we are here to support, to help, to walk this way with you and with all our Chinese friends and colleagues. It's very unfortunate that now with COVID we cannot see each other. I miss visiting you in China, and I miss seeing our Chinese colleagues coming to St. Jude. But hopefully in the next year the pandemic will resolve and we can see each other again. So thank you so much for this kind invitation.
Thank you. Since we have friends and guests from St. Jude, United States, so I will introduce the Chinese panelists. Dr. Gao Ju will be the moderator of the discussion time. Dr. Gao, would you like to say hello to the audience and participants?
Okay, good morning, Dr. Carlos, Chen, and all others, dear colleagues from St. Jude, and all our Chinese fellows in China. I'm Dr. Gao Ju from West China Second University Hospital in Sichuan, the mother tongue of pandas. I'm very excited for this exciting seminars. Hi.
Thank you.
Yeah.
Dr. Qu Shaoyan is our old friend. Fuzhou Children's Hospital is the St. Jude Hospital. Dr. Hu, would you like to say hello to all the audience and participants?
Hello, everyone. Nice to see you.
Thank you. Dr. Zhang Rui is from Beijing Children's Hospital. Hi, Dr. Zhang. Would you like to say hello to all the audience? Dr. Zhang?
Good morning, Carlos, and good evening to every colleagues from China. I am from Beijing Children's Hospital, and I am interested in histiocytic disease.
Thank you. Welcome. Dr. Wu Xiaoyan is from Hubei province, China. Dr. Wu, would you like to say hello to all?
Hi. It's my honor to attend this meeting, this conference. Thank you.
Next slides. 还有一张，前面一张，晨晨前面有一张。Yeah.
有一点慢，您看。
Dr. Wang Jiayi is from Guangdong province. Dr. Wang, do you want to say hello?
Hello, everyone. Have a nice day. I'm come from Guangzhou Children's Medical. Hi.
Welcome. Dr. Zhang Ai is from Hubei province. Dr. Zhang, would you like to say hello to all?
Good morning, Dr. Carlos, and good evening, everyone in China. I'm Dr. Zhang from Tongji Hospital in Wuhan.
Thank you. Welcome. Dr. Liang Chun is from Hunan province. Dr. Yang.
Hello. Good morning. Nice to meet you. I'm in train to Guangzhou. I'm sorry. Hello.
Thank you. We can hear you very clearly. Thank you so much for participating. Then Dr. Wang Dao is from Henan province. Dr. Wang.
Good morning, Dr. Carlos. Good evening, everyone. I'm Dr. Wang, and I came from the first affiliated hospital of Zhengzhou University. I'm very interested in this topic.
Welcome. The last panel is Dr. Wan Ling. Dr. Wan Ling is the colleague of Dr. Hu Shaoyan. She is also from Suzhou Children's Hospital. Hello, Dr. Wan. Would you like to say hello to all the audience?
Hello, everyone. Good morning. I'm very happy to take part in this seminar.
Thank you. Welcome. Now I will hand over the microphone to Dr. Gao Ju. Gao Ju, it's your turn.
Okay. So good morning, Dr. Carlos, and good evening, everybody here. So as you might have noticed, today all our dear pediatricians from China, all across to China, so I'm very excited to have the opportunities to discuss with you, your groups about the biology and treatment of lung cancer histiocytosis. Well, my fellow doctors told me that there are over 1,500 audience online. So the topics today is the biology and treatment of lung cancer histiocytosis. So I'm very happy to have you to discuss with us about these topics. So please, Dr. Carlos.
Thank you. Thank you very much. It's a pleasure for me to be here with all of you. I know that it's very late in China and you are probably very tired after a very long week. So I hope that over the next hour or so, and I'm happy to stay longer as needed, we can go over some of the key concepts of Langerhans cell histiocytosis. A lot of the comments that I will make, a lot of the information that I will share is probably very well known to you, but I will try to just put it all together. And please stop me anytime if you need clarification or if you have any questions. So what is Langerhans cell histiocytosis? So we know the Langerhans cell histiocytosis is a clonal proliferation of Langerhans cells that can affect multiple organs and systems, that the clinical presentation and the outcome are very variable. Historically, there have been different diseases that have been considered Langerhans cell histiocytosis that were described independently, like eosinophilic granuloma, localized skin disease, multifocal bone disease, and then some of these historical names like Hanschüler-Christian or Letter-Sieve disease that were part of this multi-system disease. All these different diseases are part of the same, and it's basically just a grading of least involvement to more involvement. And this is basically more almost like a family of diseases than one single disease. We also know now that regardless of the presentation, regardless of the clinical severity, whether it's a single skin lesion or multi-system disease, the histopathology looks exactly the same, which are these collections of pathologic Langerhans cells with interdigitating cells, macrophages, T lymphocytes, multinucleated giant histiocytes, and eosinophils. And the eosinophils are what give the name eosinophilic granuloma. On the top of the slide, you see electron microscopy that showed the Verbeck granules. The Verbeck granules used to be required in the past for diagnosis of LCH, but now we can diagnose LCH just with the staining of CD1A and Langerhans. Langerhans is basically the staining for the Verbeck granules of CD207. So we'll review these four components. We'll talk a little about the presentation, talk about the epidemiology, the biology, and the treatment. So let's start with the presentation. So Langerhans cell histiocytosis, as we have said, can affect many different organs: skin, the mouth, the bones, the lungs, the brain. The most common, though, is the bone. So 80% of the cases affect the bone, followed by the skin. And then all the other organs, going from liver down to the gastrointestinal tract, have lower percentages. But it's a very systemic disease that may present in different combinations of all these organs. I show here a few slides that show some of the typical presentations. A typical one, as you see in the top left corner, is an eosinophilic granuloma of the skull, of the bones of the head, that shows with tenderness, with soft tissue mass, and the X-ray shows this large lytic lesion. A very common site as well is the vertebral body, and so it's very typical for a Langerhans cell histiocytosis to result in collapse of the vertebral body, leaving what we say here, which is it's a vertebra plana. Or in the long bones, what you see is the typical radiolucency, a lytic lesion that is different from malignancies or high-grade malignancies in the fact that usually does not destroy the bone in a very aggressive manner. I just showed a picture of a PET scan because LCH is very positive on PET scan, and then a few other typical presentations: lung disease, particularly in infants or in adults that are a smoker, and then the brain disease that we'll talk a little bit later that goes with neurodegeneration. And here are some pictures of the skin disease that we'll talk a little bit later, that present with the cradle cup, like eczema in intertriginous areas, like the skin folds, but also involvement of the gums and then the oral mucosa, leading to what we call the floating teeth syndrome with the involvement of the teeth. So the epidemiology of Langerhans cell histiocytosis is not very well known. It's just because Langerhans cell histiocytosis is not included in the majority of the registries, the cancer registries, so the population-based studies are not very helpful. There are several studies that were published over the years in Europe mostly, showing an incidence of somewhere between 2.6 to 9 cases per million population per year, which is low considering all the ages. So that would be a similar incidence to, say, Hodgkin's disease. So it tends to be underreported or under-recognized, but this is basically 3 to 4 per million per year. Children 0 to 14 is a similar incidence to some type of lymphomas. Here in the United States, we did a few studies a few years ago, because in the registries, the only type of Langerhans cell histiocytosis that is documented is disseminated LCH. So that is multi-system LCH. So we ran a few studies using the SEER database, the population-based studies, and I will show you very briefly here, so that multi-system LCH is basically a disease of the first year of life. So the incidence is very high in the first year, but then it drops, and very few cases of LCH involving multiple organs after the second decade of life. We also notice that it's a slightly more frequent, or the incidence is a little higher for females compared to males. What we found here in the United States, it would be interesting to see what is the ethnic distribution in China, is that in the United States, this type of multi-system LCH is much more frequent among Hispanics, almost twice as high than in non-Hispanics. And the same with the race. So it's almost 3 times higher among whites than among blacks. So as following children with Langerhans cell histiocytosis, we tend to see more Hispanic children, less black children. And so that's a phenomenon that we do not understand very well. And I wonder if then in other parts of the world, similar ethnic and racial distributions are seen. And then the other point that we found is that in general, we tend to see Langerhans cell histiocytosis, or at least the disseminated form, in children that come from poorer neighborhoods or poorer or less educated families. So house crowding, so poor, a lot of people living in the same house, and low education among the parents are associated with an increased incidence of disseminated LCH. We don't know what that means, but that definitely means that there is an environmental and an ethnic or germline factor that needs to be investigated. So the biology of LCH has dramatically advanced, or our knowledge has dramatically progressed over the last 10 years. So this is the eosinophilic granuloma that I showed you that shows multiple, but basically, can you still hear me?
Yes, we can, Dr.
Yes, we can.
Yeah, okay, something popped up in my screen that my microphone was not working. So, but basically what you see in this eosinophilic granuloma is this pattern of multiple cells coordinated by the Langerhans cell, histiocytosis cell, with this dialogue with a cytokine storm, stimulating and recruiting macrophages, lymphocytes, and eosinophils. And that's the microenvironment is very rich in interleukins and cytokines in general. And what we see is that the Langerhans cell has an uncontrolled clonal proliferation, is arrested in an immature, partially activated stage with this deviant regulation of the cell division, with these aberrant interactions with the lesional microenvironment. So that is what we know about Langerhans cell histiocytosis. The problem has been, what is the cell of origin? And so progress has been made over the last 5 years or 10 years that I will summarize here. So the Langerhans cells, now it's known, that come from hematopoietic derived antigen presenting cells that acquire dendritic lineage and are positive for Langerhans. That is what we can say about a Langerhans cell histiocytosis cell. However, the Langerhans, the CD207, is not limited to the epidermal Langerhans cells. As we know, the Langerhans cell histiocytosis was named after the Langerhans cells of the skin because it was thought that this was the cell of origin. And then the other point that has been shown is that the CD207 positive cells of the Langerhans cell histiocytosis lesion express several genes that are associated with immature myeloid dendritic cells. So then we know now that the Langerhans cell histiocytosis lesions do not arise from epidermal Langerhans cells, but from the accumulation of bone marrow-derived immature myeloid dendritic cells that then recruit activated lymphocytes. So now we can say that the cell of origin is not the skin. The cell of origin is a hematopoietic precursor from the myeloid lineage. So Langerhans cell histiocytosis can be considered a myeloid malignancy. So the second question has been for many decades whether Langerhans cell histiocytosis was true neoplasm or was an inflammatory or reactive phenomenon. And all these affected the way we treat Langerhans cell histiocytosis, as many as you know, because it was not clear what was causing Langerhans cell histiocytosis. But all this changed about 10 years ago, in 2010, when Dr. Rollins in Boston discovered or reported that the 2/3, 57% of all the lesions of Langerhans cell histiocytosis had a BRAF V600E mutation. And so the fact that an oncogene was defining the disease, and not only the mutation, but all the lesions show activation of the ERK pathway, meant that this disease was defined by an activation of the MEK ERK or BRAF-MEK ERK pathway, therefore considering this a typical malignancy. So now we know that the cell of origin is a bone marrow-derived myeloid cell, and this is not an inflammatory phenomenon, but this is a neoplasm. And so when we put Langerhans cell histiocytosis in the scope of all the malignancies of humans, we see that adult malignancies tend to have high, very high mutational rates, whereas pediatric malignancies tend to have very low mutational rates, as we see here. And Langerhans cell histiocytosis have very little, just basically the BRAF mutation and nothing else, basically. And so this fits probably in this pattern of low mutational rate for pediatric malignancy. So now this is how we define Langerhans cell histiocytosis, a disease of this pathway, the RAS-RAF-MEK ERK pathway. And what we see is BRAF activation and BRAF mutations, or in general activations of MEK and ERK. And so there are different mutations that have been described in this pathway. ERB3 mutations, 64% are BRAF V600E mutations, but there are a few other cases of BRAF alteration that's basically deletions or duplications or even fusions, accounting for close to 70% of diseases about BRAF alterations. Then about 12% have a mutation of MAP2K1, which is the gene that encodes for MEK. And then there are still about 15% of the cases that we don't know where the mutation is in this pathway. So what we know is that the BRAF V600E doesn't have a significant correlation with the presentation, high risk versus low risk, age, gender, single versus multifocal, or overall survival. But we have seen in many different studies that patients with a BRAF V600E mutation tend to have a higher probability of recurrence, but the overall outcome is not significantly different. And then the other point that discovering the BRAF V600E or describing it has helped us is that we can detect, as you very well know, circulating cells with BRAF V600E, and so that allows us to map out the burden of disease a little bit better. So when we compare patients with a single bone lesion, non-risk disease, with multi-system disease, or with high-risk disease, you see that you can increasingly document circulating cells that are positive for BRAF. So that systemic disease and localized disease seem to have two different patterns of presentation. And this has been used as well many years ago. It was described, but it's still used in some places as a good way to monitor the burden of disease, and response to therapy. So when you have a big group of adult patients in this case that were studied for detection of cell-free DNA for BRAF V600E, you see that the majority of patients can have circulating DNA, and that in response to therapy, you see significant declines. So it's not very commonly used, but it's a way to help with diagnosis and to help understand residual disease. Then another point that I bring this here during the biology is the LCH of the central nervous system. So in the left, you see a picture of a patient with a typical presentation, with this phenomenon of neurodegeneration that, as you know, happens sometimes 5 to 10 years, and which biology has not been very clear. We know from some of these studies that have been done by Dr. McLean and Dr. Allen in Texas, is that this is a unique disease, or a unique biology. So we see BRAF in the CSF, but the most common is osteopontin. But what's more important is that when you do biopsies of these lesions, you see diffuse perivascular infiltration by BRAF V600E cells that don't look like Langerhans cells. These are different types of cells, probably glial cells that express or are mutated for BRAF V600E. And we also know that these patients respond when treated with BRAF inhibitors. We'll get back to this in a minute. And so this is basically, when we put it all together, what seems to make the whole story. So during development, the yolk sac cells populate the microglia in the brain. Fetal liver cells populate the epidermal Langerhans cells. And then the bone marrow, gives rise to the hematopoietic stem cells and monocytes that eventually can go to the brain and can go as well to the skin. So what we think that happens in Langerhans cell histiocytosis is what you see here. So if we look at the frequency of BRAF allele mutations, we can come up with this theory. So if the mutation occurs in the hematopoietic stem cells, you can have then a patient with multifocal high-risk disease. If this mutation occurs in a blood precursor, you have multifocal lesions, but not involvement of the high-risk organs. If this mutation already occurs in a cell that is committed to the tissue, then you may just have a single bone lesion. So depending on where this mutation occurs, you have more or less advanced disease. And to explain the clinical symptoms that we have right now, so you could say, if it's a mutation that occurs during the fetal development, fetal liver, since the fetal liver precursors populate the skin, you may have skin-limited lesions in the newborn, but not involvement of the rest of the organs. And then in patients with Langerhans cell histiocytosis, depending on where the precursor is, you can have multifocal lesions, but you can also have this neurodegenerative LCH that can populate the microglia. So this is more or less how we put it together. So depending on where this mutation occurs, you may have more or less advanced disease. So you need a mutation in the BRAF-MEK ERK pathway. And depending on where that mutation occurs, whether it's a precursor, a CD34 cell, or a committed tissue cell, you will have more or less disease. From a skin-only disease, if it's in a fetal liver cell, to a multi-system disease, if it's in a CD34 positive cell. So that helps us understand the clinical presentation. And then we'll talk now about the treatment. So we have talked about single system presentation, depending on where the mutation occurs. And then you can have bone or skin or lymph node or lung disease. If you have more than one or more than two organs, we call it multi-system disease. It's usually patients that have with bone and skin. That's the most common presentation, but you may have also lymph node disease next to the bone lesions or lung disease. But then we have also known for many years that depending on which organ is affected, there is a high risk of death. And so particularly this has been known for the liver, for the hematopoietic system, and for the spleen. So liver, hematopoietic system, and spleen are considered high-risk organs, and this is why we call multi-system with risk organ involvement. So this way we have three categories of disease: single system, multi-system, and multi-system with risk organ involvement. How are we doing with the treatment? So we have made major progress over the years. So this is a population-based study looking at multi-system disease that we did looking at registry data. And so we have seen that over the last 2 or 3 decades in the United States, for example, we have seen major progress with a relative survival at 5 years that has increased from 70% to 90%. Why is that? I think that because we understand better the disease, we treat it better, and then also because we have been able to optimize the treatments with more intensive chemotherapy for these patients. So I will tell you about 2 studies, the LCH3 that has already been published, and then the LCH4 that is currently ongoing, and then a few other treatments that are coming down the pipeline. So let's just start with LCH3. The LCH3 has already been published and you know it, but basically tried to address 3 main groups. One, the high-risk group, the patients with multi-system disease with risk organ involvement, a low-risk group, which was multi-system disease without risk organ involvement, and then patients with bone disease in special sites. Let's just start with the low risk. The low risk are patients that don't die of the disease. So patients with multifocal bone and skin disease, for example. But the problem with these patients is the reactivations. They keep reactivating. Up to 40 or 50% of these patients keep reactivating for many years. You treat them and then they reactivate again. So the question was, can we prolong therapy? And if we prolong therapy, will this decrease the reactivation rates? So the treatment was a randomization of the standard prednisone vinblastine between 6 and 12 months. So it's a standard of care, induction with prednisone vinblastine for those patients that had an intermediate response, had a second induction, and then randomized to 6 versus 12 months of therapy. For high-risk patients, the problem is not so much reactivation, it's survival. These are patients with liver disease, with spleen disease, with bone marrow involvement. And so the question in this study was, can we add chemotherapy, add methotrexate, for example, to improve the survival? And so the patients were randomized to receive or not methotrexate, and the treatment was 12 months for everyone. So here you see the treatment. You are very familiar with this. Induction with prednisone vinblastine, reinduction for intermediate responses, then maintenance therapy with prednisone vinblastine and 6-MP in this particular case, with or without methotrexate, which was intermediate dose during induction and low dose during maintenance. And here are the results that were published already 7 years ago. So for patients with risk organ involvement, the survival was the same for patients that received methotrexate or not, with a survival slightly above 80%. For patients with multi-system disease without risk organ involvement, the survival was 100%, and there was no difference between prolonging therapy for 12 months or keeping it at 6 months. What was interesting, though, is that it showed that prolongation of therapy decreased the reactivation. So as you see here, 12 months on both cohorts of patients leads to a reactivation rate of about 30%. But for the other group, the multi-system with low risk, if you treat for less than 12 months, 6 months, that reactivation rate doubles to almost 60%. So these were the basis for the LCH4 study. So then, could we further decrease the frequency of reactivations by more prolongation of therapy or by adding 6-MP? What are the best salvage treatments for low-risk disease, and what are the best salvage treatments for high-risk disease, that is to decrease mortality, and then to investigate CNS disease. So some of you are familiar with this study. It's a big study with 7 different strata, different groups of patients. The frontline study for all patients with multi-system disease is like this. Is patients start with prednisone vinblastine. Those that are risk organ positive and do not respond to induction, rather than going to the reinduction, are switched to salvage therapy that we will describe. All the others go to a reinduction and then have a double randomization to prednisone vinblastine or prednisone vinblastine with 6-MP for 12 months or for 24 months. So we have 4 groups: prednisone vinblastine for 12 months, prednisone vinblastine for 24 months, prednisone vinblastine 6-MP for 12 months, prednisone vinblastine 6-MP for 24 months. And this is how the study is going. Then for the low-risk reactivation patients, the treatment is with single agent RAC with vincristine and prednisone. We'll talk a little bit more about that. And then a randomization to either indomethacin or 6-MP and methotrexate. Then we have the group of high-risk reactivation, the patients with multi-system involvement with risk organ disease. And so here I will show a paper that was already published 5 years ago, which was a study of the International Histiocyte Society as well, a phase 2 study looking at high-dose cladribine and cytarabine. I will not show you that because it's very cumbersome, but you can look at the paper yourself. But basically, it's high-dose RAC, 500 milligrams per meter squared twice a day, and high-dose 2-CDA or cladribine, 9 milligrams per meter squared per day. This is a very intense treatment. It's almost like AML therapy. But for these patients, it worked very well because the survival with this regimen was close to 85%. The problem, though, it's a very toxic regimen. So the 2 patients in this study of 27 patients died not of disease, but of toxicity. So these patients need to be treated like an AML. So using this data, the LCH4 was built to treat patients with high-risk reactivation with the same regimen, 2-CDA and RAC. Here you have the regimen. I don't have to describe it to you, but basically it's an induction with 2-CDA and RAC. For those patients that have no active disease, go into maintenance therapy that includes cladribine alone. And for those that have progressive disease, we're supposed to go to a bone marrow transplant. However, there was an interesting paper published 4 years ago from Argentina showing that you could induce very good responses in these patients with much lower doses of cladribine and cytarabine. So half the dose of cladribine from 9 to 5, and 1/5 of the dose of or less of cytarabine, 100 milligrams per day for 5 days. Just this low dose combination, as you can see in the table below, can induce long-term responses as well in patients with high-risk disease. So it's a good combination when you have maybe if your hospital is less equipped to support the patient with AML, or the patients live in more difficult conditions, so that cannot tolerate supportive care or toxicity. So anyway, that's a good regimen to consider. And then for those that reactivate or do not respond, go to high-dose chemotherapy and a stem cell transplant. Then you have this other group of patients that we discussed earlier, the central nervous system disease. Patients with LCH have this endocrinologic sequela with diabetes insipidus, multiple endocrinopathies, but also neurologic sequela with neurodegenerative disease. That's a big challenge in the treatment of LCH. And so I refer you to this paper that we published from the NACHO consortium a couple of years ago that has a lot of information about how to evaluate these patients, what type of studies, what type of imaging, and how to treat them as well. So I will not describe this in detail here, but just to mention that the study, the LCH4, includes a stratum for those patients, for patients that have tumorous lesions, big lesion in the brain. We recommend treatment with 2-CDA or RAC. For patients with neurodegenerative disease, when the study was formed, we still did not have all the information about BRAF. So we have been recommending RAC or data from Japan that suggests that we can treat these patients with IVIG. However, now I would recommend treating these patients with a BRAF inhibitor, as I will describe later. And then you have all these patients come together for a follow-up. And so over the last 5 or 10 minutes, so we can have time for questions, I will go a little bit over new treatments, alternatives, or new agents, or old agents that can be used, like single agent RSC, second-line therapy with nucleoside analogs, indomethacin and bisphosphonates, and then we'll spend more time looking at the BRAF inhibitors. So let's start with cytarabine. Cytarabine, RSC, as a single agent without vincristine, without prednisone, works very well, particularly for patients with reactivated disease. The doses are not very clear, between 100 and 170 milligrams per meter square for 3 to 5 days. I recommend 150 milligrams per meter square for 5 days at the time of relapse. But in adults, where prednisone and vinblastine are associated with a lot of side effects, cytarabine alone has been used with a lot of success. And so here in this table, in this paper, basically just shows the responses with a progression-free survival of 90% for frontline therapy and 40% for recurrent. But the idea is that cytarabine works very well. Then in the family of nucleoside analogs, we also have clofarabine. Clofarabine is more effective, much more effective in my view, than RSC, but it's also more toxic. And so there are different studies that have been published looking at clofarabine. And it's a very good agent at a low dose, 20 milligrams per meter square per day for 5 days, can induce also very good responses. Then we have hydroxyurea. Hydroxyurea, which is a low-cost medication that can be given orally, that here in the United States we use for children with sickle cell disease, can work very well, particularly if you have a patient that cannot come to the hospital, that needs oral medication and has a reactivation. That might work well. So the same dose that we use for sickle cell disease, 20 milligrams per kilo per day. And in this study that came from Houston, showed 53% of these patients had a complete response, 27% had a partial response. So 80% of these patients responded. So consider hydroxyurea for a low-risk reactivation in a patient that wants to take oral medicines. And then we talked a bit earlier about the randomized regimen for low-risk reactivations on LCH4 that included indomethacin. And this is an important point because for patients that have bone lesion only, we need to look at how these bone lesions develop. And so the Langerhans cells, as we had seen earlier with that cytokine storm, can produce or induce the production of IL-1 that activates the osteoclasts and cause bone lysis, or PGE2, prostaglandin E2, that causes bone resorption in itself. And so we can deactivate this pathway using bisphosphonates or using indomethacin or even some other NSAIDs. And so there is a study a few years ago looking at indomethacin, which is a very simple medication treated for a long period, for up to a year or so, 2 milligrams per kilo per day, and that in 22 patients at diagnosis of bone disease treated only with that, 18 responded, and all the patients treated with just bone disease at relapse also responded. So it's a good agent as well that can be given orally for patients with reactivation of bone disease. And similar studies, as you know, have been published for bisphosphonates. Many studies, I just show an old picture here from about 2 decades ago, but you can use pamidronate, etidronate, zolendronic acid. Many studies have shown, and it's useful, particularly in adults with chronic reactivation of LCH. But then obviously the most relevant new treatment is BRAF inhibitors. And so the discovery of the BRAF mutations in these patients led to a new field in the treatment of LCH. And so there have been very few studies. I highlight this one that was published from multiple countries that put together 54 patients treated with BRAF inhibitors. And basically you see there were 44 patients that had risk organ involvement, then that did not have it, but 8 weeks of treatment, and there were 38 complete responses, 16 partial responses. So basically almost all patients responded, The problem, as you see in the bottom, is that as soon as you stop the treatment, the patients reactivate, particularly those with multi-system disease. On the right, you see the waterfall plot, and you see that all the patients with a BRAF mutation responded. So all of them responded. The problem again is as you stop the treatment, many of these patients reactivate. This is another study that we published as well here in the US with a group of patients treated with a BRAF inhibitor, and that shows great responses, but again, reactivations as you stop the treatment. And at the bottom on the left, you see what I was mentioning, patients with neurodegenerative disease, patients that were treated long ago that then developed this memory loss, ataxia with posterior fossa changes, and how a BRAF inhibitor was able to induce a response and a clinical improvement. And you see this here. So in many patients with Langerhans cell histiocytosis with neurodegenerative disease that you see in these MRIs, treatment with a BRAF inhibitor may induce a partial response or even a complete response. And I will conclude with this picture, with this paper. So now that it's the time to discuss, cell therapies and CAR T cells, can Langerhans cell histiocytosis also be susceptible for some of these treatments? And yes, so there was recently, a few months ago, a paper of a CD1A specific CAR T cells for patients with ALL, but that could be potentially used as well for patients with Langerhans cell histiocytosis. So to conclude, Langerhans cell histiocytosis presents with this wide spectrum of clinical presentations that combine features of neoplastic proliferation with inflammation. The treatment with the standard vinblastine prednisone results in survival rates of greater than 85%. However, as we know, about 30% of the patients reactivate or relapse. So the challenges right now is how to treat patients with risk organ involvement, the patients with liver, spleen, bone marrow disease, that still 10 to 20% of these patients die. How to manage the reactivations and how to minimize the reactivation rate. So it's about prolonging therapy, about intensifying therapy, how to understand, how to prevent, and how to treat the late effects and the neurodegeneration, and then what to do with the molecular therapies. So now we have BRAF and MEK inhibitors that can be used for treatment of LCH and, baby with a multi-system disease, liver involvement in critical care. You give them vemurafenib, and the treatment results in an almost complete response in 2 or 3 weeks. The patient leaves the ICU, the critical care, and is fine. The problem is that you stop the medication and the disease reactivates. And so how to manage that? So do we have to combine a BRAF or a MEK inhibitor with chemotherapy, and how and for how long? So these are the questions that the next years of trials will have to answer. And then finally, what would be the role of some of these potential cell therapies in the management of these patients? And so with that, I will conclude. I thank you all for staying late and taking the time to listen to me, and I will be happy now to start with any questions. Thank you.
Okay, thank you, Dr. Carlos. Okay, very nice presentations, also covering from the basic science to clinical related issues. So any questions from our fellows, doctors, any questions?
I have 2 questions.
Okay.
Yeah, my first question is about some patients with multifocal bone involvement. They got relapsed again and again by all kinds of treatment, which include the first line, the second line treatment, targeted treatment, and also indomethacin, even permethrinate. They still got relapse and relapse. Could you please give us some suggestion for this kind of patients? That's my first question. And my second question is the dosage and duration of targeted treatment. Will it be beneficial if we combine target treatment with chemotherapy. If we do so, such as dabrafenib should be given continuously or during the interval of chemotherapy. Thank you.
Yeah, this is a very good question. So let's start with the first one, and I don't think I have a good answer for you because I have had the same problem with the same patients that reactivate and constantly reactivate after multiple treatments, and others that after just one reactivation you can cure. So I think in these cases what I have opted is then to treat with an oral low dose, like hydroxyurea, for example, for a year, for 2 years, for 3 years, and hope as the patients grow that the disease intensity will dissolve, right? So will improve. So, but I don't think I have a good answer for you. My main concern with these patients is that the multiple reactivations may lead to CNS disease, neuroendocrine problems, etc. And so I try to then keep them on low dose something for a long period of time without allowing the disease to reactivate. So for the other, for vemurafenib, so I don't know, I cannot tell you for sure. I haven't used vemurafenib in combination with chemotherapy, so I don't know what would be the right way to modify the dose. Many people are doing that. And I hear that's the big challenge, because I think that we can all treat with vemurafenib, and we can, target the dose to the responses. But the problem is that for a patient with multi-system disease, as soon as you stop, will reactivate. So I think the question is how to combine with chemotherapy. So my personal opinion is that, for example, for a patient with multi-system disease, the next trial probably would have to be a vemurafenib or a MEK inhibitor together with clofarabine, for example, or RAS-RAF-MEK for about, an induction of 6 months or so. Then continue with clofarabine and stop the vemurafenib. I think the vemurafenib can help with rapid responses, can help with clinical stabilization of the disease, and it can help, hopefully, with chemotherapy to induce long-term responses. But the problem is how to design a clinical trial that responds to that. Probably will have to be a randomized clinical trial with and without, probably a double randomization that includes the duration. So maybe you in China can do this type of trial. I think it would be an interesting trial to explore.
Okay, thank you. We can have cooperation. We can do it together.
Yes, happy to work with you. Definitely, it would be an interesting trial.
So actually, so let me ask this kind of question. So the further, where as you mentioned, there are a high rate of reactivation even with targeted service. Well, if a patient with refractory LCH respond to VMF, so how long would you recommend? This is question number one. Secondly, so in terms of VMF and the dabrafenib, which dosage or which agent would you recommend?
Yeah, yeah, going to the first question, the duration of the treatment, I really don't know. I cannot answer that. I think that for a patient that has low-risk disease, for example, multifocal bone disease, I think that the risk of reactivation after stopping therapy is lower. So maybe in that case, I would say a year and then stop and see what happens. For patients with multi-system disease, I would not stop it. I would, not stop it. I would probably try to then combine with chemotherapy at some point before I stop it. Yeah.
Okay. This is a question from our audience. The question reads like this. As for relapsed refractory LCH disease with PROF positive gene, so what dose of inhibitors of dabrafenib should be given and for how long?
Oh, that's a good question. I don't know. I would have to look back at my files about the best dose for dabrafenib. for vemurafenib, because they have been different doses, and I cannot tell you right now. I'm sorry. And the dose, I would just optimize the dose based on what has been published. I don't have it right now in my brain. But in terms of the duration, is basically what we were discussing. I think if it's a patient with multi-system disease, with liver disease, a spleen disease, bone marrow disease, this patient cannot be stopped. So this, I would just treat this patient for a long period of time, at least 12 months, and then think about, combining with chemotherapy to induce a permanent response.
Well, as I know, for glioma, the initial dosage for this kind of agents is 3 milligrams per kilos. So do you agree with this dosage also works for LCH?
Yes, I think I can look as we talked to in my files, but probably that's in this study at the JCO. There was a pharmacokinetic evaluation, so the doses were adjusted for systemic exposure, and I can look right now at what was the dose that most of the patients received for vemurafenib.
Okay. There is a lot of question from our audience, which like this: what to do if a patient with a Langerhans cell histiocytosis who already suffered from blindness? So what could we do?
So I don't understand. So blindness due to the Langerhans cell histiocytosis?
Yeah.
Wow.
Most probably because of the liver degenerations.
Yeah. So that's a very, I have a few patients with severe neurodegeneration that did not respond at all to BRAF inhibitor. So if you already have blindness, I mean, for any patient with neurodegeneration, I think that my first approach right now would be to treat with a BRAF or a MEK inhibitor. So if we know that the patient had a BRAF V600E mutation, I would do the dabrafenib. If the patient did not, then I would use a MEK inhibitor like a cobimetinib or something like that. But that would be my first choice for a patient with neurodegeneration. Now, if not all patients respond, because if it's a long-standing neurodegenerative process, there is no recovery. So I don't think that you can make any big difference.
Can I ask two questions?
Yes.
My first question is quite clinically. Which imaging method do you suggest to identify bone disease? X-rays, CT, or it's a very clinical question.
No, that's a very good question, because we all consider, so the standard is X-ray, right? So I usually do a skeletal survey, just X-ray, and I usually then combine it with a nuclear medicine study. There is a bone scan or a PET scan. I like to do PET scans, and the PET scan for LCH is very sensitive. So I usually do always a skeletal survey and a PET scan.
So this is at the diagnosis. So during the treatment.
During the treatment.
Will you repeat these PET scan, or you just do the PET scan again when the patient has symptoms?
Yes, then I think that for LCH, the clinical symptoms are a good guide for management, and you want to minimize radiation exposure. So if a patient is responding very well with no symptoms, I think that you can follow clinically, maybe with focused X-rays in some of the lesions if you want. Usually what I do is that if the patient has multifocal bone disease, at some point after induction or reinduction, I may repeat a PET scan, but after that, I don't. I usually follow these patients clinically.
My another question is about recurrent lung disease. Currently, we have a patient with recurrent lung disease. The patient is short of breath and he needs oxygen all the time of the day. And the BRAF is we cannot detect no BRAF mutation for this patient. So do you have any suggestion for such kind of patient, recurrent lung disease?
Right. So the lung disease is oftentimes difficult to, as you know, to manage because it has the active Langerhans cell lesions, the nodular lesions, but then the cysts and the emphysema that oftentimes happen secondarily, and that causes a lot of the respiratory disease, pneumothorax, etc. So it's always important to understand if we are dealing with progression of the emphysema or progression of the active disease. And so for the active disease, I like to see nodular lesions. If what I see it's only, cysts, emphysema, then I think it's more, a long-term effect, and that we just need to then to support this patient with oxygen until the lungs, recover. If the patient has active disease with nodular lesions and progressing, then I think that if the patient has failed all the treatment plan is only, then I would just go for every, all the treatments. So if the patient has doesn't have a BRAF mutation, I would probably try with a MEK inhibitor. That would be my next choice. But I think that if you have still not tried with RAS or with clofarabine, these are still very effective agents to treat patients with progressive disease. But the point is how to differentiate between active LCH in the lung and that progression of cysts. Same happens with the liver. How to differentiate active liver involvement from sclerosing cholangitis, the biliary cirrhosis. And oftentimes they coexist, but then at some point the disease resolves, and then what you have is only the sclerosing cholangitis.
We just do the biopsy to understand if the patient is disease progression or just suffered from the sequela of the
yes.
disease. Mm-hmm. Thank you.
So I have a question, Dr. Karras. Okay, recently I have 2 young infants who suffered from a massive intrathoracic mass. So it turned out biopsy, it turned out to be an LCH. So because of the gland, intrathoracic thyroid gland is very massively enlarged. So after six-week induction chemotherapies, well, the clinical situation improved remarkably, and PET scanning showed that there is no active disease, but the gland remains large. So the question is, how would you evaluate with this kind of patient? Would you regard it is an active disease or lung active disease?
So the mass was in the thymus?
Thymus.
Yeah, this is a good point. So the thymus is a target organ for Langerhans cell histiocytosis, and infants may present with very enlarged thymus. So, it's difficult to constantly biopsy these lesions, and so the size may not always reveal what is the activity, and a PET scan will not help you because the thymus can be always hot. So I don't know how to follow these patients. I had also one patient once like this. So I assume that the size was did not correlate with activity. So I would continue with the treatment and only change treatment if I saw progression. Okay. But you see what I mean? I just don't know otherwise how to do it.
Okay. So any questions from our dear colleagues?
Dr. Carlos, do you think for some LCH patients, if they sensitive to the BRAF inhibitor, but we cannot stop the inhibitor treatment, do you think these patients can be the chronic disease? They should use the inhibitor for a very long time, such as CML patients, they maybe whole life. Do you think there's the possibility for such kind of patient?
Yeah, there is a possibility. I would like to think though that eventually there is a possibility of stopping. I think we are so early in the development of the BRAF inhibitors, right? So just, you know, the first papers were published over the last 2 years, so we still don't know, you know, when to stop and how. My 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 guess is that for many of these patients, you know, the treatment may just need to be prolonged for 2 or 3 years. Yeah, definitely. And then at some point, periodically try to stop it. But down the road, the big question is how to combine it with chemotherapy.
Thank you.
Okay, another doctor asked such a question. As I understand, the question is a possibility that a single system LCH would develop to multi-system LCH. If it does, is there any risk factors which would help us to predict the risks?
So say it again. So if it's possible for
single system LCH to develop into multi-system.
Yeah. So in general, the only cases that we tend to see single system that evolves into multi-system is a skin disease, right? In infants. So a child that presents with a severe skin disease that then over 2 or 3 months evolves into multi-system disease. In general, you don't tend to see a patient with multifocal bone disease, then developing liver or spleen. So it's usually during the first year of life, children that present with a skin disease. And you know, there are these studies that I showed earlier that the circulating BRAF positive cells or cell-free DNA levels might anticipate or might predict multi-system disease. So I would say that maybe for a baby that presents with just the skin disease, very severe skin disease, if the patient has high circulating levels of BRAF V600E DNA, most likely this patient will progress into multi-system disease. But I don't think that we can say that for sure right now.
Thank you.
Thank you. Any question?
I have another question. How can we differentiate sclerosing cholangitis or LCH activation of the liver? You know, even sometimes we do the biopsy, it can answer the question.
Yeah, this is a very difficult clinical problem because you need to rely on a biopsy in the majority of the cases. So and then time. You know, if you see a 6-month-old infant with severe liver disease, then cholestasis, and then you see progression of that, most likely it's both things. You know, active disease in the liver, inflammation around the biliary tract causing some cholestasis. Now, 2 years later, you know, once you have controlled the disease, then you only see progressing sclerosing cholangitis, then I would say that most likely this is just sclerosing cholangitis. And then now that we can detect BRAF V600E, I think it's important then to just try to do molecular analysis of these lesions and see if you can identify the mutation.
Yes. Can PET-CT scan help?
I don't think so. I think that a PET may help if you have a nodular lesion, but since PET tends to be so the liver is so FDG avid, I think that the PET doesn't help too much.
Okay, thank you.
I have a question, Dr. Carlos. Why can we use IVIG for patients with neurodegeneration?
Yeah, that is a theory that IVIG can help with some of the immune dysregulation that happens in the CNS disease. These are studies that came from Japan, as you probably know, and that showed some improvement in patients with CNS neurodegeneration after IVIG. Personally, I have never used it, and I don't think it really works. But if you don't have any other option, patient has neurodegenerative disease, you have treated with BRAF and inhibitor and doesn't work, you have tried with RSC doesn't work, then you can try IVIG. But personally, I don't think it's such a good treatment.
What do you think that, well, that dosage as shown in your slides, IVIG, the dosage 0.3 or 300 to 500 milligram per kilo would be effective? Because for IVIG to exert a therapeutic dosage, it should be immunomodulatories.
Yeah.
It should be a little bit higher in terms of dosage, right?
Yeah, I agree.
Yeah.
So that would be the high dose, at least 1 gram per meter square.
Right.
And so I don't think that the data that comes is very significant. But as you know, in Japan they use it, and there have been 2 or 3 papers that show some improvement. But also some of these patients improve on their own without IVIG. So.
Okay, thank you. Dr. Gao, shall we make a conclusion?
那我们就晨晨 next slide. Thank you so much, Dr. Carlos. Lots of questions and a busy morning for you. So thank you all the audience and all the participants, and thank you, Dr. Carlos. So next, so thank you so all the presenter and the participants, and I will say a special thank you to Brandy, Karen, Morgan, and Chen. So thank you for your input. And please, all the audience, I will say, please stay tuned for our next St. Jude and SCMC Pediatric Oncology Seminar Series. The next topic will be rhabdomyosarcoma. Thank you all. So
Thank you. Bye-bye.
Good night, my colleagues in China. Have a nice weekend.
Yeah,
and
thank you.
thank you, Dr. Carlos. Have a nice day for you.
Thank you. Have a good night and a good weekend. We'll see you soon.
See you soon.
Bye-bye.
Bye-bye, everyone.
Bye-bye, everybody. Bye-bye, everybody.
Bye-bye.